talk is not going to be as heavy on clinical information as Dr. Bull's, unfortunately. But I'm going to try and discuss some of the general factors that apply to all rare disease patients and how those factors can create risks for medical child abuse accusations. And if at any time you have a question, please write that down. There should be a couple minutes for questions at the end, and we can pass in however Julie wants to do it. So, okay. Wrong way. All right. What is a rare disease? There are a couple different definitions, and there's two that we're going to focus on here today. The first is the National Institute of Health definition, which is any disease in which fewer than 200,000 individuals are affected in the U.S., not the world, the U.S. This is very U.S.-centric. So that encompasses about 6,000 to 7,000, depending on who you ask, different rare conditions. And about 1 in 10 Americans in total is affected, so about 30 million adults and children. And usually they estimate about half of those are children, so about 15 million children and about 15 million adults affected with some form of a diagnosed rare disease. Okay, so there's another definition also that we're going to talk about, which is the care experience definition of rare diseases, which is basically patients who experience their disease as a rare disease, even if it's not technically less than 1 in 200,000. Okay, so what does that mean? These are diseases that are rarely known, things that may affect as many as, 1 in 2,000, 1 in 3,000 patients, but doctors don't know about the diseases. They're not taught in medical schools. Nobody has any idea what it is if you say the name. These are diseases with few to no expert specialists, clinics, or hospitals. So even if you get a diagnosis, you can't go anywhere to get treated. You're not going to find an expert. So effectively, your disease is rare because nobody knows what it is and nobody knows how to take care of it. Diseases with few studies in the medical literature and few FDA-approved treatments. This is really important because in today's day and age where we're very focused on data and outcomes, we practice, quote, evidence-based medicine. If there are no studies on your disease in the medical literature, nobody is going to be either thinking seriously about your disease, knowing how to treat it, and it's going to be more controversial overall simply because we don't have, quote, the evidence. And diseases with controversial diagnoses, controversial treatments, controversial abilities to be identified. Mitochondrial disease is actually considered a controversial treatment and diagnosis disease in some corners, as in we can't completely identify everybody who has a mitochondrial problem. We can't always identify a one single or multifactorial molecular basis for the disease. We don't know how to treat it. There are many different ideas on how mitochondrial problems should be treated, and there are a lot of diseases like that out there, which we're going to talk about a few of them. Okay, and then undiagnosed conditions. I think it should always be remembered that if you have an undiagnosed medical condition, you are effectively a rare disease patient because nobody knows what you have, nobody knows how to treat it. All right. So what is medical child abuse? Because what we're talking about here is the sort of overlap between medical child abuse accusations and rare diseases. So what is medical child abuse? There is no single clear answer, and that's the bad news. Medical child abuse, like some of these undiagnosed or controversial other diseases, is not a clearly defined entity that has one single definition. In fact, it has multiple definitions. We're not going to go into all of them today, but we will at least cover some of them. There are many names to start with. Munchausen syndrome by proxy, caregiver fabricated illness. The first is the oldest name assigned to medical child abuse. Caregiver fabricated illness is what the American Academy of Pediatrics likes to use. Factitious disorder by proxy or factitious disorder imposed on another, the American Psychiatric Association. Medical abuse, medical child abuse. That is from a couple American child protection pediatricians. Pediatric condition falsification, and there are actually even more than this. Each one of those names has a slightly different definition and is identified in somewhat different ways, and that has a big effect on who gets accused and why they get accused. All right, so many different definitions, but we're going to break it down into 3 frequently cited types of medical child abuse. The first one is fabrication and infliction. These are the people who lie about their child's symptoms or deliberately cause them. Like, there's just no doubt this is child abuse. You're suffocating your child to pretend that they're having apnea episodes, you're poisoning your child, or you're fabricating symptoms like adding your blood to your child's urine and then telling the doctor your child is, having renal bleeding. This is deliberate abuse. Child abuse, no question. Okay, manipulating care. this is where it starts to get a little fuzzier. This could be a deliberate problem or a non-deliberate problem, depending on who you talk, and it includes things like parents who exaggerate symptoms. Oh, doctor, Johnny was vomiting 10 times last night. Maybe Johnny only vomited 3 times. The parent may be, exaggerating on purpose so that the doctor's like, bring Johnny to the emergency room right now, he needs IV fluids. Or it could just be a normal function of speech. Sometimes parents are anxious, sometimes they're prone to be, to overstate the problems. Okay. By the way, manipulating care also includes intensely anxious parents. Doctor, something's really wrong. I'm telling you, we just need to do something. They come to the office over and over again. Some doctors might eventually give in to that and be like, okay, Mrs. Smith, we're going to treat Sally's, viral infection with some penicillin. Here you go. Now please go home and take a chill pill. Relax. So there are doctors who would respond perhaps by changing their care based on how anxious or assertive the parents are, and that could be seen as manipulating care. And then the last form is over-medicalizing. And I would say that this is probably where many rare disease families have the most trouble. Over-medicalizing may or may not be deliberate, and it basically includes the idea that your child is receiving medical care that he or she does not need. And since all medical care comes with some form of risk, you are in fact harming the child if you're treating them for something that they don't need to be treated for, i.e. penicillin for their cold. The child doesn't actually need that antibiotic. So this can be deliberate or it may not be deliberate. It could be the mom or dad who wants more care just because they are, like the idea of more care. It could be the parent who believes the child really needs more care. It could be doctors even treating child for wrong diagnoses, treating children too aggressively. It's a very vague and broad concept, and I would say that this is where there is a lot of overlap with rare disease patients. So the key concepts for medical child abuse, they're behaviors, usually by the caretaker, that cause or create a risk for harm, medical harm, to the child through direct injury, such as suffocation, poisoning, or through unnecessary medical treatments, whether that's intentionally manipulating the care so that the doctor gives children a treatment that they don't need, unintentionally becoming so anxious or so hypervigilant that a doctor is finally like, here, just go home. Here's the treatment. Leave me alone. All right. So, in addition to that, there's something else we need to talk about, which is the medical child abuse or the Munchausen syndrome by proxy profile. This is not evidence. Unfortunately, it's kind of like that bad rumor that your next door neighbor told about you in junior high. Everybody knows it's false, but it just won't go away, and it still colors how people treat you. That is what the MSBP profile is. It is something that sound minds in all of medicine and child protection work do not really believe describes child abusers, but it just doesn't go away, and it still influences some doctors' perceptions of who may or may not be abusing their child in a medical setting. All right, so the first risk factor for this is being a woman, 2 X chromosomes, mother, grandmother, aunt, nurse. Unfortunately, we all know that there are people in the world who are misogynistic. There is a long history of gender bias, and it still affects medical care. It does. All right, attention-seeking personalities, anxious, demanding, assertive, weepy mothers, people that make life difficult for doctors and other care providers, having a background with medical or science. If you are a nurse, an EMT, a pharmacist, a scientist, any of these things in some people's minds make you more at risk for medical child abuse because you're, quote, smart enough to fake the symptoms. So, a woman who is, quote, manipulative, won't leave her child alone in the hospital, argues with the doctors, demands specific treatments, is really involved in the medical care, doctor shopping, doctor splitting. We're going to go over that. And a woman who, quote, and this one always kills me, enjoys the caregiver role, really likes being in the hospital for, that month at a time, or likes having a sick child. If caregivers sometimes, in some of the cases that I worked on, they've been like, well, mom just really likes to be here. She's friendly with all the nurses. She's always bringing them coffee. She's, she just really chats them all up. Clearly, she just loves having a sick child and being in the hospital all of the time. All right. And then having a family history of similar symptoms, i.e. a history of mental illness, personal health problems, multiple ill children in the family, and unfortunately even a prior history of having lost another child. So these are the things that some doctors look at this, a mother or another female caretaker who has some of these symptoms, and they think to themselves, oh, there's something wrong there, because this mother might really be able to fake her kid's symptoms, and she's got a history, another child died in the family, and she's having some similar problems herself. There really could be medical child abuse going on here. Well, this is a problem, because I'm sure some of you are seeing similar things about your own family here. This is a problem because it has a lot of overlap with the rare disease community. All right. So how and why rare disease patients are more vulnerable to medical abuse accusations? All right, 3 specific situations we're going to go over, 3 case examples. And each one of these is a family. It was a mother who was accused. In each one of these cases, the children were temporarily removed from the home, so these were very serious cases that all went into family courts, DCF, custody of the children. It was very traumatic for each of the families, and there was a rare disease involved. All right, case 1. This is the Udvardi family. They are from California. The Udvardi family, mom Leslie was the one who was accused of medical child abuse. Leslie and her husband have 4 children. All 4 of those children at different times in their life have had medical symptoms that were originally unexplained. So, Loma Linda, California, rare disease, initially undiagnosed. 4 children with a multiple year-long history of undiagnosed symptoms, and Leslie herself also has undiagnosed symptoms. So we're already starting on the Munchausen's profile here. Eventually, by the end of this case, the diagnosis turns out to be hypermobile Ehlers-Danlos syndrome with Chiari malformation, a rare disease. And in fact, at the end of the case, Leslie and all 4 of her children and Leslie's adult brother all end up diagnosed with this condition. All right, so what are the facts of the case? So Leslie is taking her children, to multiple specialists over multiple years, multiple hospitals, multiple clinics. We don't know what's wrong. My child has symptoms in their nose. They have symptoms in their skin. Their joints hurt. They're tired all the time. They don't want to go to school. They have anxiety. They have these headaches that are disabling. Over and over again, the doctors run tests. They come back normal. Nobody knows what's wrong. And eventually they say to Leslie, look, we don't know what's wrong, but it's not really that serious. Take your kids home, stop with the medical care, live a normal life. But Leslie won't. She says, no, something is wrong with my children, and I want answers. So she begins to do her own research. She goes online, she starts searching symptoms. She comes with, hey, Ehlers-Danlos syndrome. It looks like it fits some of these cases, maybe even Chiari malformation. So she goes and she looks for specialists. She finds a clinic in New York. She contacts the clinic. They're willing to see her children. She goes back to her team and says, hey guys, I think I know what's going on. We're going to take our kids out to New York. They're going to get an evaluation for EDS and Chiari malformation, and then, hey, they can do surgery. They can get all better. We can go on with our lives. And the doctors say, whoa, we told you to go home. We don't think your children need any more invasive testing. We don't want them going to see these specialists in New York. These treatments are highly aggressive. They seem unnecessary. This is too much. They file with DCF. They accuse Leslie of medical child abuse. She is over-medicalizing her children. She is harming them. She is, in fact, exposing them to very dangerous care for no reason whatsoever. She doesn't need any more medical consults. We told her to go home. All right, what's the takeaway from this case for rare disease patients? The risk factors with Leslie and the Udvardi children for a Munchausen's or a medical child abuse accusation: undiagnosed medical problems in multiple people. Nobody knows what's going on, just a lot of sick kids in one family. Seeking multiple medical opinions over many years. Many hospitals, many clinics, many specializations. A mother with an anxious personality. Everybody who has met Leslie Udvardi throughout this case describe her in some way as anxious and hypervigilant. And if you guys know what hypervigilant means, it means that every single little problem that was wrong, Leslie was going to the doctors. My daughter's ear hurts, the roots of her hair hurt, her toenails are funny, like everything. She was a hypervigilant, anxious mother. Doctors found that annoying, and they thought that made her very prone to exaggerating her children's medical problems. She was a mother who self-researched and suggested her own diagnosis. The doctors didn't like that. These are all factors for medical child abuse. So the main medical abuse concern in the Udvardi case was something called doctor shopping. Doctor shopping is when a parent who does not have legitimately sick children deliberately changes doctors around the country in order to find the ones who will give her that penicillin for her child's cold. All right, I've been to 3 pediatricians and they all tell me no. The rhinovirus doesn't need antibiotics, go home. So I'm going to keep going around and around and around to different pediatricians until I find the one who says, here you go, here's your amoxicillin script, go home. So, all right, it usually involves multiple doctors, multiple specializations, multiple hospitals and clinics, multiple states and countries, and usually multiple years. So how does this affect the rare disease family? What's the rare disease overlap here? Okay, so according to a survey done in 2013 by Shire of rare disease patients in the US and the United Kingdom, the average rare disease patient will need to see 8 physicians before finding their rare diagnosis. Yes, 8. So that means multiple doctors in multiple hospitals, in multiple clinics, over multiple years. 7.6 years is the average time to a rare disease diagnosis in the US. So you can already see where the problems are coming. All right, 2 to 3 wrong diagnoses before the right diagnosis is made for the average rare disease patient. So already we can see, why was Leslie Uvardi in trouble? Clearly, she fits the bill for doctor shopping. Unfortunately, most rare disease patients and families fit the bill for doctor shopping. What's the medical ethics perspective here? All right, so parents who are not fabricating or inducing their child's symptoms, i.e. their children are having these symptoms, they have a right to seek multiple medical opinions. They do. The American Medical Association clearly states that physicians should obtain consultations with other doctors when they believe it would be medically indicated, but also when requested by the patient or the patient's representative, i.e. the parent. So I'm not faking my child's symptoms. The child is truly sick. You can't find out what's going on. I have a right to ask that we go see a different doctor. I do have a right to take my child to multiple medical specialists in search of that diagnosis. But know the risks. You have this right, but that doesn't mean there aren't going to be negative consequences for it. So what can we do? All right, keep perspective first off. You know, when we've been taking care of sick children for a long time, or when you're a patient who's been sick for a long time, it's really, you know, sometimes things just get so overwhelming that any little symptom is like the straw that broke the camel's back. You know, you wake up one day and the pain in your left elbow is there that's never been there before, and you just had it, and you call the doctor over everything, and you just want answers, and you want them now. Try and keep perspective. Hypervigilance and anxiety generally are not going to be perceived favorably by physicians. Don't overshare. I cannot say this enough. Do not go to every single one of your child's 15 specialists and tell them every single thing you've researched on the internet, every single diagnosis you think that they might have, the fact that you want to take your child for the 7th medical opinion. Keep these things for your child's core team. What is the core team? This is very important. All rare disease patients and families of rare disease patients need to establish what is called a small core team. That is a pediatrician or a primary care doctor that is good and trustworthy. It is a rare diagnosis disease expert. So if your child has Ehlers-Danlos syndrome, you want to have one trusted EDS expert on there. If your child is undiagnosed, you want to have one main specialist who helps to coordinate the testing and the procedures for this, for finding the diagnosis, and a few key specialists. So if you're one of Rick Bull's patients and you have this triad of fatigue and pain and GI symptoms, then you might have a metabolic specialist to help with your mitochondrial problems, and your key specialists are going to be, you know, GI and a pain specialist and maybe somebody to help with the fatigue and a good pediatrician. That is your core team. Everybody else is an outside specialist. They don't need to have all of the details of every single thing that's going through your head or happening in your child's life. Your core team needs to be communicating and caring and providing the care coordination with these outside specialists. We're going to talk about that more later. That's very important, and it's one of the main ways that I have found is successful in preventing reoccurrence of child abuse accusations in families who've gone through one, and in preventing child abuse accusations in rare disease families. Case 2. This is another Californian family. Christine Deese was actually a family practitioner. She is a doctor. She has 2 children, both adopted, but this case mostly concerned her daughter. There are multiple cities in California where this case took place. All right. The rare disease involved here was cystic fibrosis. Christine's daughter had cystic fibrosis. She also was premature. She'd been exposed to drugs at birth. She had developmental delays. She had multiple medical problems. This was a kid with a lot going on in addition to a diagnosis of cystic fibrosis. So, Christine Deese, family practitioner, doctor, very smart woman, incredibly competent and confident advocate for her daughter. She's taking her daughter around to different specialists. She wants to see the best specialists here, one at UCLA, one at Loma Linda, a couple doctors in different hospitals and clinics all over California. She wants the best care for her kid. Well, what ends up happening, unfortunately, is Christine, her daughter has been hospitalized in multiple of these clinics. They're not communicating with each other. There's no intensive care coordination going on. There's no one team leader other than Christine herself. Nobody knows what's happening at UCLA. Nobody knows what's happening in Loma Linda. People aren't talking to each other. Dr. Dietz gets into a fight, an argument, over a treatment decision with a doctor in one hospital. They don't go contacting anybody else. They do a minor record review of the things that have happened in their hospital, and they say, we didn't test this kid for cystic fibrosis. Where did she get that diagnosis from? Who made that diagnosis? They don't call her. They don't call around to talk to her child's other doctors. Instead, they go straight to their child protection team who says, wow, mom is crazy. Clearly she could make up these diagnoses. She's a doctor. She's fabricating this diagnosis of cystic fibrosis. Both children go to foster care, just like that. Child protection gets involved. DCYF takes custody of the kids. They go to foster care. So, and unfortunately, the state of California did not make out well in this case. It took about 2 years, but Christine Dietz eventually got the courts to review all of her daughter's records. It was clearly evident that the child had cystic fibrosis and multiple other medical problems. She turned around and sued the Kern County, won $1.2 million in a settlement for a gross violation of her civil rights, and has been really angry and very outspoken about false accusations of medical child abuse ever since. What happened in this case? Let's see. All right, what were the risk factors here for a medical child abuse accusation? Multiple hospitals and multiple clinics. Poor to no care coordination or communication between the specialists. The only one who knew what was going on overall in her daughter's care was Dr. Dietz herself. There was not one doctor who really had the whole picture. It was the specialist here, specialist there, UCLA, different doctors knowing different small pieces of one large picture. It was a mother with medical knowledge. She was a doctor, pediatrician, and a woman who had a complicated kid. Big Munchausen's risk. She was very assertive and very involved in her child's care. She was known to be pretty confident, maybe even aggressive by some of the doctors who didn't like her so much. All right, the main medical abuse concern here was something called doctor splitting. This is a term that is used by child protection specialists to describe parents who deliberately take their children around to lots and lots of specialists and keep the doctors from talking to each other. It can be things like saying, please don't send your clinic notes to my child's PCP. Like, I just want this hospital to know what's going on in ENT. I want a different hospital to be the only one that knows what's going on in my kid's GI care. A different hospital to be the only one that knows what's going on with my child orthopedically. And therefore, the fear here is that if that's happening, that it's very easy for the parents to manipulate care, to make it so that the GI doctor gives one diagnosis, ENT gives a totally different diagnosis, orthopedics gives something different, and instead of everybody putting the pieces together and perhaps figuring out that this child isn't really sick after all, but is being abused, the mother or the caregiver is more easily able to trick, to manipulate, to deceive the providers. So doctor splitting. Okay, involves multiple doctors, multiple specializations, multiple hospital clinics in multiple states and countries. Again, pretty clear to see what the rare disease overlap might be here. 76% of US doctors report that they have trouble coordinating care for rare disease patients. Right off the bat, we have a big problem. If lack of care coordination can contribute to a medical child abuse accusation, and 76% of the doctors in the US say that they don't do a good job coordinating care for their rare disease patients, we already have, 1 foot through the Munchausen's door. 92% of US doctors report that their rare patients have more care needs. They need to go to the hospital more often. They need to see more doctors. They are going to have more care information to coordinate. They're going to have more clinics involved. They're going to have more doctors involved. So if we go back to that 76%, it becomes an even bigger problem, because these are patients, as we all know, who have many specialists, and they're not being well coordinated. 60% of US rare disease patients themselves and caregivers report problems from lack of communication between doctors. So right away we can see why the rare disease patient is in a setup for an accusation of doctor splitting, because we don't do a good job coordinating rare disease care. These patients have a lot of specialists, they have a lot of needs, they have a lot of hospitals and clinics involved most of the time, they don't talk to each other, and we already know that over half of the patients are currently experiencing care problems from lack of coordination of care. So what's the ethics perspective here? All right, Doctors are the ones responsible for care coordination. Often it feels like parents and caregivers and patients themselves are the ones who have to be ferrying the information back and forth to all of the clinics. GI said, ENT said, orthopedics said, but that's not the case. It's actually the doctor's responsibility to coordinate care. It's not an easy responsibility on them, by the way. This is not to throw doctors under the bus. They have limited time. They don't have a lot of resources, but it really is their professional obligation to coordinate care. American Medical Association, the physician has an obligation to cooperate in the coordination of medically indicated care with other healthcare providers treating the patients. Not easy to do, but ultimately it's not the patient and the family's job to make sure that care gets coordinated. However, parents can help or hurt communication. Dr. Deese was not medically abusing her daughter. She was not actually committing physician or doctor splitting. Unfortunately, she was accused of doctor splitting. She was accused of medical child abuse because the way that communication was being managed in her care team, she was actually hurting care communication. So, how can we reduce risks? Back to the small core team of physicians. Trusted expert, trusted PCP or pediatrician, few key specialists, and all major care decisions need to be made here in the care core team. So your child may need surgery or a serious medication or to undergo a very unusual or difficult treatment, say over in immunology, one of your accessory outside specialists. But before you just sign your name on the dotted line, you go back to your child's core team and say, hey, immunology wants to give my kid high doses of IVIG to see if we can put a suspected autoimmune disease into regression. You don't just go off and do it. You make sure that the core team knows all of the things that are going on in your child's care, agrees with it, assesses it, speaks to the immunologists themselves if they have questions. So other specialists need regular communication with your child's core team. This is essential. Care communication, care coordination is absolutely essential, not only to keeping your child or yourself healthy and preventing medical errors, but it is one of the most reliable ways to prevent a medical child abuse accusation. So, facilitate communication directly between doctors. I think a lot of us have done this if we have children or other people that we take care of with complicated medical issues. We go to one doctor, we show up the pediatrician says, hi, Mrs. Smith, what did the GI doctor say when you saw her last week about Sally's continuous vomiting? Oh, let me tell you, pediatrician, and then you give a whole verbal report. And the pediatrician takes some notes, and 2 months later, the pediatrician says, oh, well, you know, the GI note didn't say any of the things that you said. You said the GI doctor is giving Sally a suspected diagnosis of cyclical vomiting syndrome. Well, that's not in the note. So now it's mom reports. Mom reports diagnosis of cyclic vomiting syndrome. Doctor didn't say anything about it. Don't do that. If the pediatrician wants to know what the GI doctor said, tell the pediatrician to call the GI doctor. Look for the clinic note. Read the clinic note. If there's very important information that you need to communicate at that appointment, say, what I understood the doctor to say was that possibly Sarah has a diagnosis of cyclic vomiting syndrome. But until the doctor himself or herself makes that diagnosis concretely, this is simply a verbal report of what I understood. Please confirm with the doctor. This, I cannot stress this enough. Parents doing the go-between as the communicators is a huge setup for problems because doctors say things to us that they don't write in their clinic notes. We may misunderstand, we may not hear correctly. The doctor may forgot, what we consider to be an extremely important detail, like, Sarah's last 3 KUBs were possibly diagnostic for pseudo-obstruction, may have been an afterthought to the GI doctor, but to us, that was, the most important information in the clinic visit, and we go around telling everybody that Sarah has pseudo-obstruction. But that's not how the doctor intended it to be taken. It's very important that the doctors communicate directly with each other. Clinic notes, testing data, phone calls, emails, care conferences. These are all necessary for the doctors to also have, not just the parents. Christine Deese was the only one who knew what was going on in her daughter's overall care picture, and that is why she was extremely vulnerable to an accusation of medical child abuse. Your doctors need to be getting clinic notes. Your core team needs to be involved in the care conferences, phone calls, testing data, not just you. All right, again, no verbal reports from parents. Again, I cannot stress this enough. It is not something that we do on purpose to cause trouble in a child's care, but it is something that can and does cause trouble. All right, case number 3. Case number 3 is actually over 2 families, and Most of you probably know at least one of these stories. Some of you may know both of them. Both of these are young teenage girls, Elizabeth Ray, or they were at the time of the case, and Justina Pelletier and their families. Both of these cases took place in Boston, Massachusetts. Elizabeth Ray originally came from New York, and Justina originally came from Connecticut. All right, rare disease. Two rare diseases involved here. Pediatric, that should actually say acute onset, not autoimmune, so I apologize. Pediatric acute onset neuropsychiatric syndrome, otherwise called PANS, and mitochondrial disease. Most of you probably know that both of these conditions can be considered controversial, and that even if they are confirmed with a diagnosis, that there are many different opinions on how to treat them. So what are the facts of the case? All right, so Elizabeth Ray was diagnosed with PANS by a group of doctors in New York. She was started on the treatments of long-term antibiotics. She responded very well via the reports of both her doctors and her family and Elizabeth herself. Symptoms improved. She had an associated eating disorder with them. And because the hospital in New York where she was being treated did not have an inpatient unit that was used to dealing with medically complex teenagers who had eating disorders, she came to a hospital in Boston that did. They consulted the hospital about their eating disorder program. They did not consult the hospital about their opinion on PANS and how it's treated. Same thing with Justina Pelletier. She contracted the flu in January of 2013. She was instructed to go to a hospital in Boston where her GI doctor worked because her main symptoms were GI problems. She went there to see her GI doctor. However, there was no discussion, unfortunately, with the core team and the hospital before she went about their opinions on mitochondrial disease. What is it, how is it diagnosed, and how should it be treated or not? So both of these girls arrive at this hospital in Boston, and although they are receiving treatment initially for the reasons that they were sent there, it takes a difficult turn in both cases. For Elizabeth Ray, the hospital in Boston decides that they don't really believe that this child has a diagnosis of, acute onset neuropsychiatric disorder. They pull her off her long-term antibiotics. They stick her in their psych ward. The parents object, understandably so. The New York doctors object, understandably so, but at this point it's a little too late in the game. The child is inpatient in the Boston hospital. The parents lose custody after an accusation of medical child abuse is made, the accusation revolving around the idea that they are harming Elizabeth by giving her treatments of long-term antibiotics for a disease that the hospital's not even sure actually exists, and if it does, that it really shouldn't be treated this way in this case. Same thing with Justina Pelletier. The hospital objects to the diagnosis of mitochondrial disease. The hospital objects to some of the treatments that she's being given. They pull the treatments, they pull the diagnosis. Parents object, other medical providers object outside the hospital, but it's a little too late in the game at that point. The parents are accused of medical child abuse for interfering with their daughter's proper treatment of what the hospital believes is a primary mental health condition, and for endangering her by providing treatments for a disease that they do not believe she has. Both of these young women are out of their parents' custody for a number of months before they are finally reunited and the cases are closed. All right, what is the takeaway for rare disease patients here? And I just want to say right up front, I am not a doctor, so I am not making any sort of value judgment on whether these diseases are real, on how they should be treated, on who has them and who doesn't have them. I'm simply reporting that these were the cases as they were reported in the media and in the courts, and these were the outcomes, and here's how it affects rare disease families. All right, what were the risk factors for the medical child abuse accusation in these two cases? They were the same. Controversial diagnoses with controversial treatments. I think every single medical provider I've ever met is able to admit that we don't know everything in medical science. We cannot diagnose all treatments or all diseases, and we do not know all treatments. So there are entities that we look at in the medical world where we say, there could be something here, there may not be something here. To think of a really controversial diagnosis in this area, chronic Lyme disease. I have no opinion on whether it exists or not, but it is very controversial. There are many doctors who say there is no such entity, there are doctors who say there is, and then there are many different opinions on how it should be treated. Controversial diagnoses and controversial treatments automatically up the level of suspicion for medical child abuse. What's next? All right, arguments between physicians and hospitals without resolution of the professional dispute. This is a big problem. We already saw in the last case that more than half of US doctors, 76%, say they can't do a good job coordinating care for their rare disease patients. So when they actually have an all-out disagreement with each other, it's difficult to get it resolved. If you have doctors in UCLA saying Christine Deeth's daughter has cystic fibrosis and doctors at Loma Linda saying no, she doesn't, and they don't talk to each other and they don't resolve that dispute, that ups the risk for a medical child abuse accusation, because you have doctors in one place saying you're treating the child for something she doesn't have, and doctors at the other place saying you're not treating the child appropriately if you pull her off these treatments. All right. Concern for mental health and psychiatric disorders. This becomes a really big problem when children enter the teenage years. A rare disease patient between, about the ages, I usually say like 9 and 29, tends to be at pretty high risk for a misdiagnosis of psychiatric or mental health problems, or an accurate diagnosis of comorbid mental health or psychiatric problems. There is a lot of comorbid mental health conditions in my experience for the simple reason that it's really difficult to live with a rare disease. It's really stressful. There's absolutely nothing unusual about developing stress, anxiety, or even depression when you live this life for years. But it can be an increase in factor for medical child abuse accusation, and that if you have a mental health disorder, sometimes doctors are confused about whether your physical symptoms are actually a separate condition or do they just result from the mental health disorder. All right, and the final thing that was a risk factor for both of these families, for both of these teenage girls, was the fact that they were receiving invasive and possibly harmful medical treatments. So one child was receiving long-term antibiotics and a number of other treatments, and another child was periodically using a feeding tube. She had had surgery to flush her colon, from the top, so she had a small tube, an opening into her abdomen. She'd undergone surgery. They were both on many medications. So these were treatments that if these children did not have these diseases, they didn't need, and they were potentially harmful. So potentially harmful treatments, confusion about what the diagnosis is, arguments between the doctors, all of these things were the huge risks for a medical child abuse accusation in these two rare disease patients. So what were the main medical abuse concerns here? The main medical abuse concern in these two cases was something called over-medicalization, which I touched on earlier, which is the idea that when a child is being over-medicalized, the child is being harmed with unnecessary medical treatments, tests, surgeries, drugs, hospitalizations. We all know that medical treatments in and of themselves can cause harm. Every time you go in for a scope or you have to have a minor surgical procedure done, the anesthesiologist hands you that 5-page release that says if you die under anesthesia, because sometimes that can happen, you're releasing the hospital from liability, it's informed consent. Medical treatments are not without cause of harm. They are not without potentially negative consequences. If somebody is perfectly healthy, they shouldn't be taking multiple medications, going through surgeries, going through many diagnostic tests. This idea, by the way, is really important in medical ethics. So I want to make it clear that even though over-medicalization can be a really gray zone that can have a lot of negative consequences for rare disease families, it is important to think about it. This is one of the reasons that we don't just subject people to medical experimentation. If you're perfectly healthy, there's nothing okay about me filling your body up with drugs, cutting you open for no reason, subjecting you to tests. It's not okay. All right, so what was the other main medical abuse concern? A controversial rare disease diagnosis. Unfortunately, controversial diagnoses have achieved a reputation, right or wrong, in the medical child abuse world, in the child protection world, as being an easy target for parents who want to fake their child's symptoms. Some of you may know that there was, in fact, an article that came out of the Cleveland Clinic several years back that specifically named mitochondrial disease as a diagnosis that parents who have Munchausen's like to fake. So, there is a reputation for controversial rare diseases. Chronic Lyme. I've worked on a lot of medical child abuse cases where the diagnosis in question was chronic Lyme. I've worked on several where the diagnosis in question was Pandis or PANS, where it was mitochondrial disease, where it was CRPS, where it was Ehlers-Danlos syndrome. All of these diagnoses have achieved, and unfortunately, a reputation for being, quote, easy to fake, or ones that parents who are committing medical child abuse like to go after. All right, so what's the rare disease overlap here? This was actually achieved from insurance providers, both the state and private ones. 90 to 100% of U.S. patients with a rare disease need more diagnostic tests, more medical appointments, and more prescription drugs than anybody else. So already there's a risk for over-medicalization because we're accessing medical care much more often than anybody else. if you're a patient or if your child's a patient, they're going to be on more medications than a perfectly healthy child. They may need to undergo a lot of diagnostic tests to get to that rare disease diagnosis. As we saw, an average of 8 physicians and 7.5 years to get the rare diagnosis in the United States means a lot of testing, a lot of consultations, a lot of medications that you try and fail or try and fail again. It means a lot of different medical interventions in an attempt to both diagnose you and then treat you after you've been diagnosed. So automatically, you are accessing more medical care. It puts you at a higher risk for an accusation of over-medicalization. All right, 60% of US rare patients report conflicting opinions from their doctors over how to treat their rare disease. So we know that doctors have difficulty coordinating care. We know that having a care argument over what the diagnosis is and how to treat it is a risk factor for a medical child abuse accusation. 60% of rare disease patients already have that risk. We know it. They go to their doctors and they get told very different things about how to treat their child's condition or their own condition. So this is unfortunately another area of very serious overlap with suspicion for medical child abuse. This is not a problem that's going to be easily solved. If you put 5 doctors in a room and you ask them how to treat the same condition, you're going to get 4.5 opinions. So it's unfortunately, as medical professionals have a right to make their own assessment, their own judgment, and to formulate treatment recommendations. And we can try and standardize the process to some degree by focusing on evidence-based practices, things that have been tested on large numbers of patients. The American Heart Association likes to talk about, the best standard of care, best practice for treating things like high cholesterol levels or cardiomyopathy. But they've tested those trees aren't looking at treatments. It's hard to have a standard of care for a disease that is not being researched or treated anywhere. Conflicting opinions, very high risk for medical child abuse. And again, an average of 2 to 3 wrong diagnoses for a rare disease patient. And I'm sure some of you can say that you've had 5 times as many as wrong diagnoses. Depending on what the symptoms are, some rare disease patients go through many, many wrong diagnoses before the rare disease is actually found. And this increases your risk for a medical child abuse diagnosis because if a doctor says you don't have mitochondrial disease, you have somatization disorder, and that's a wrong diagnosis, but the doctor really believes it's right, and another doctor really believes it's mitochondrial disease, you have a problem. Very, very different treatments associated with each of those diagnoses. What's the ethics perspective here? When licensed physicians cannot agree on how to provide care, parents should be able to choose between the treatment options for their child. Should be able to choose. The American Medical Association says, when there is a legitimate inability to reach consensus about what is in the best interest of the child, the wishes of the parents should generally receive preference. This is very important, but I will have to say it's actually one of the medical ethics principles that I find is least observed in many of the cases that I work. And that's very unfortunate, and there may not be anything you can do about it if the doctor or the medical team that you're working with just doesn't believe that your preferences should generally receive preference, but technically speaking, there really is, from the medical ethics perspective, the parents do have preferential decision-making ability when doctors cannot decide between treatments. Now we're going to say between treatments, not as in Dr. A recommends a G-tube, Dr. B recommends feeding therapy, and the parent chooses a central line placement. That's not what I mean. What I mean is Dr. A recommends a G-tube, Dr. B recommends feeding therapy. They cannot agree. The parent can choose based on the child's best interest, their understanding of the child's best interest, their understanding of their family's best interest. The child should be able to sit down with those 2 physicians and say, I feel that it would be in Sarah's best interest if we try the G-tube, or I feel it would be in Sarah's best interest if we try the feeding program. Since you both agree these are possible treatments and we can't decide if one is better than the other or not, my family's values and priorities and Sarah's interests as far as I understand them lead me to say, let's do intensive feeding therapy. Does that make sense to everybody? Okay. All right, so choose your care wisely. You may have this right to help choose care, to participate in choosing care, but you need to choose wisely or there can be very negative consequences. So how can we reduce the risks? Licensed doctors, MD or DO, and avoid extremely controversial treatments whenever possible. You may think that that is like common sense, but I've actually had cases where parents are getting their treatment from somebody who is not a licensed doctor. That is not a good decision. That is not a good decision. Not to say that other providers cannot add things to medical care, but if you are dealing with a rare diagnosis or you're involved with a rare or controversial diagnosis or treatment plan, you need to try as much as possible to stay within licensed medical professionals. Those are the ones who have been trained and licensed by the states to provide medical care. And when possible, avoid extremely controversial treatments. The doctor may say you have the option of taking your child down to Mexico for some rare and unusual and extreme treatments. If you can think of a different way to treat your child's issues, please don't go to Mexico instead. That is not going to work out in your favor when you are standing before the family court judge. I assure you, I've seen it happen many times. Avoid extremely controversial treatments whenever possible. All right, stick to the experts. Do not go to clinics and hospitals and doctors who know nothing about your rare disease diagnosis and who do not want to know anything about it or who do not believe it exists. Again, this seems like common sense, but the reality is we have access to a lot of different clinics and treatments in this country, and even in this state. We have a lot of good doctors here. You would think that every doctor should be able to treat condition X or condition Y, but it's just not the case. And if you have a rare disease, then you've already experienced this, or if your child does, that there may be an ENT that your daughter's preschool mommy group everybody loves, and he puts in the best ear tubes, but you take him there to deal with your child's rare form of palate cleft, and he doesn't have any idea what it is. He's never done that. He's never dealt with it. He may be a great physician for these other parents. He is not a great physician for your child. Stick to the experts. That really involves working with your core team, like we talked before. This is why the core team is so important. Before you go off to see a new hospital or a new clinic, one of the best things that you can do to cut down on misunderstandings in care, unnecessary care controversies, or situations in which your child is in the physical custody of somebody who doesn't even believe their rare disease diagnosis exists, is to have a meeting with your core team of doctors before you go to new hospitals, new clinics, or engage new specialists. These are the people who are helping make the medical decisions for your child. They are the ones who know your child's medical history. They are the ones who know the family history. They are the ones who know the rare disease and hopefully have some expert training in it. They should be consulting and thinking about and doing research on who you should be taking your child to. Don't just show up somewhere when you have no idea whether that hospital, that clinic, or that doctor is able to care for your child, especially if your child has a diagnosis that is sometimes considered controversial. Stick with your core team. Carefully consider medical options. Go to the trusted physicians who know you and your child best, and together decide where to take your child for treatment. And then finally, parents need to stay out of the diagnostic and treatment fights. It's really tempting when a doctor gets up in your face and says, I don't believe that pandas exist, and you're a bad mom for giving your child long-term antibiotics, and that is just a garbage diagnosis, and we don't believe in that. It's very tempting, and it's human nature to say, you're wrong, my child needs this treatment, I know that this disease is real, and Dr. So-and-so has been treating. Don't do that. In those situations, you need to step back and say, I understand your feelings. Thank you for sharing your medical opinion. Here are the names and phone numbers of my child's core medical team. Please call and discuss your concerns with them. I am not a doctor. I do not have the right to make or take away diagnoses. I do not have the right as a parent to prescribe treatments. If your child is getting long-term antibiotics, you didn't write that script, somebody else did. So the person who has a problem with it needs to talk to that doctor, not you. And you need to stay out of that. You need to stay out of that fight or that concern or that conversation. Refer problems to your child's long-term physicians. This is very important because if you're not the one fighting, if you're not the one saying, no, I insist that you do such and such treatment, then it's a lot harder to say that you are the one over-medicalizing your child. After all, you didn't write those scripts, so you need to refer all concerns about your child's diagnosis and medical treatment to the doctors who have made those diagnoses and the doctors who have prescribed those treatments. All right, so what are some of the conclusions we can draw from this? I think, I went over these 3 cases. There are many more. I've worked about 60 cases in the last 5 years of medical child abuse accusations. I think one of them I had some suspicion might have been true, but it actually turned out that there was a bigger misunderstanding than we thought. Every single other of those 59 cases was actually a rare or undiagnosed patient who was not the victim of medical child abuse. These accusations happen, they're extremely traumatic, they're very difficult, and there is a lot of overlap between the things that make doctors concerned for medical child abuse and the lived experience of rare disease patients. Coordinating care, having to go through multiple doctors before you get your diagnosis, having to travel to multiple hospitals and clinics to find your diagnosis and then to receive care for it. Poor doctor communication, difficulty coordinating care, conflicting opinions from different specialists, the inability to get everybody in the same place at the same time to discuss problems. All of these things are part of the reality for rare disease patients, and unfortunately, all of these things are part of what lead to medical child abuse accusations. So being informed is really important. Doing your best to stay in safe practices, safe guidelines, and take common sense measures can go a long way to help you reducing accusations. So rare disease patients are vulnerable to medical child abuse accusations because many features of rare disease care overlap with medical child abuse concerns. Parents and patients can reduce the risk of an accusation by keeping and creating, if you don't have one, or keeping a small core team familiar with the rare disease diagnosis and the patient and family history, medical history, etc. All right, the core team needs to coordinate care and communicate with other doctors. We know that many of our families who have rare diseases, they see many specialists. 15 specialists can't be on your core team. It should be 3 or 4. And those 3 or 4 doctors need to be facilitating care coordination with the rest. All right, stick to doctors and hospitals that understand your rare disease diagnosis and respect the treatments that your core team is providing. Do not go, as we said before, to a hospital that does not respect any of the treatments that your most trusted medical professionals and providers have prescribed. Stay out of communication problems if you are the parent. Stay out of diagnostic fights. Stay out of treatment fights. No verbal reporting of care between physicians by parents. No defending other doctors' diagnoses. No defending other doctors' treatment plans. These are medical professionals. They can speak for themselves. They need to speak for themselves. They need to be the ones addressing care concerns in your child's care, not you. And I don't mean for that to sound harsh. We are our children's best advocates, or we as patients are our own best advocates, but because you are not a medical professional, you do not have the professional backing, the rationale, the clinical expertise to justify your child's diagnosis or treatments. You are not the right one to be defending it. Somebody else has made that diagnosis. Somebody else has prescribed those treatments who does have that clinical backing. They need to be the ones explaining to people who are concerned why they did that. All right, so these are my references, lots of references, and I'm happy to share with people when we're done. And I just want to acknowledge the faculty at Albany Medical College because a lot of this research was done as part of my thesis, and those were my 2 thesis advisors. All right. All right, so Julie, do we have time for questions?
Yeah, no, we're running way behind.
Running behind, okay.
Questions later with the forum.
No problem.
Yeah, we're running way behind, so if I